So hypertrophic obstructive cardiomyopathy, these are 60% of all cases. They're familial, autosomal dominant, most commonly due to mutations in genes, binding protein C and beta myosin, heavy chain. Causes syncope during exercise, may lead to sudden death due to ventricular arrhythmia. Sound 4, S4, systolic murmur. May see mitral regurgitation due to impaired mitral valve. Treatment: cessation of high-intensity athletics, beta blockers, non-dihydropyridine calcium channel blockers. If patient is high risk, ICD. Diastolic dysfunction ensues, marked ventricular concentric hypertrophy. Remember I said these are hypertrophy enlarged, okay, muscles thickening. Also, physiology, an asymmetric septal hypertrophy, systolic anterior motion, outflow obstruction, dyspnea. Okay. We might also have the opposite, which is dilated. Notice the large chambers. Most common cardiomyopathy, 90%. The mnemonic here is ABC, CCD. Etiologies would include alcohol, wet beriberi, Coxsackie B, chronic cocaine, Chagas disease, doxorubicin, toxicity, hemochromatosis, sarcoidosis, thyrotoxicosis, peripartum cardiomyopathy. You might have heart failure, S3, systolic regurgent murmur, dilated heart on echocardiogram, balloon appearance on the heart. Sodium restrictors could be a treatment. ACE inhibitors, beta blockers, diuretics, digoxin, heart transplant. Digoxin, there's that term again. Can lead to systolic dysfunction. Systolic, not diastolic. Okay, if you recall, diastolic dysfunction deals with obstructed. So DO, obstructed. Systolic, dilated. Let's see. You might have Takotsubo cardiomyopathy, where you have broken heart syndrome, where you have ventricular apical ballooning, likely due to increased sympathetic stimulation, like a stressful situation. Really stressful, gets really enlarged. You might also have restrictive infiltrative cardiomyopathy, and here is puppy leash is our mnemonic. You're looking for things on the test like post-radiation fibrosis, Loeffler endocarditis. That is associated with what's the long one? Eosinophilic syndrome. Histology shows eosinophilic infiltrates into the myocardium. Might also have amyloidosis, sarcoidosis, hemochromatosis. Okay. And again, this is a diastolic dysfunction. Can have low voltage ECG, even though you have a thick myocardium. Might also have heart failure, clinical syndrome of cardiac pump dysfunction, congestion, low perfusion, dyspnea, oropnea, fatigue, S3 heart sound, rales, jugular venous distension. Here's your A. Pitting enema. You push into skin and it stays indented. Systolic dysfunction. Ejector flow is reduced. EDV, contractibility. Okay. Diastolic dysfunction. Preserved EF, normal EDF, decrease in compliance, increase in EDP. Right heart failure most often results from left heart failure. Cor pulmonaire refers to isolated right heart failure due to pulmonary cause. ACE inhibitors or angiotensin II receptor blockers, beta blockers, except in acute decompensated heart failure. And spironolactone can decrease mortality. Thiazide or loop diuretics are also used mainly for sympathetic relief. Hydralazine with nitrate therapy improves both symptoms and mortality in select patients. Also, that's heart failure. You might also have left heart failure. This is where you have shortness of breath when supine, when you're laying supine. Increase in venous return from redistribution of blood. Immediate gravity effect exacerbates pulmonary vascular congestion. It's called orthopnea. Paroxysmal nocturnal dyspnea, breathless awakening from sleep, nocturnal. Increased venous return from redistribution of blood, reabsorption of peripheral edema. Pulmonary edema. This is pulmonary venous pressure, pulmonary venous distension, transudicial fluid, presence of hemosiderin-laden macrophages, HF cells, in lungs, heart failure cells. Right failure, hepatomegaly, nutmeg liver, increase in central venous pressure, increase in resistance to portal flow. Rarely will lead to cardiac cirrhosis, however. Jugular venous distension, increased venous pressure. Peripheral edema, increased venous pressure, fluid transudation. So left ventricle contracts lower, less likely, and you might have pulmonary venous congestion, might lead to impaired gas, pulmonary edema, reduced right valve output, could have cardiac output be decreased. So those are some of the outcomes you would look for on the exam. Shock, inadequate organ perfusion, delivery of nutrients necessary for normal tissue and cellular function are inadequate. Can be reversible, life-threatening if not treated promptly. So this is a typical test question they'll give you. They'll want to tell you you are having cardiac shock, and they'll ask you which way these arrows go. So this is kind of a good question. Hypovolemic shock, as you know, that deals with hemorrhage, dehydration, clammy skin. Preload will go down, carbon monoxide, cardiac output will decline. That makes sense. Notice the cardiac output declines pretty much for everything except for distributed shock. And then afterflow increases. Use IV fluids. Cardiogenic flock, acute myocardial infarction, heart failure, valvular dysfunction, arrhythmia. The big thing here, decrease, and then you might also have increase of afterload. Relieve obstruction. Obstructive shock, same idea, cardiac tamponade, so you have fluid or blood, pulmonary embolism, tension, and pneumothorax, so some pressure against your thorax, thoracic region. Distributive shock, sepsis, that's in the way of infection. Anaphylaxis, CNS injury, central nervous system. Warm and dry, so here it's a little bit opposite of the others. You'll have a decrease in preload, an increase in cardiac output, and a decrease in afterload. So think distributed down, okay, if you want to on these two. You'll administer IV fluids, pressors, and epinephrine. Okay. Some good pictures here. Bacterial endocarditis, acute. These are always good questions on the exam. Streptococcus aureus, large vegetations on previous normal valves, rapid onset. So these are bacterial infections to the endocarditis heart. Here you have, so A, there you go. Then subacute, viridans, streptococci, low virulence, small vegetations on congenitally abnormal or diseased valves, sequela of dental procedures, gradual onset. And here's B, these are some symptoms. fever, new murmur, Roth spots, round white spots on the retina surrounded by hemorrhage. So there you go, there's a retina. Osler nodes, tender raised lesions on fingers or toes. There you go. See, so toe pads. Due to immune complex depositions. Janeway lesions. These are small, painless, erythematous lesions on the palm or sole. And then splinter hemorrhages on a nail bed. E. Okay. Associated with glomerulonephritis, a septic arterial or pulmonary emboli. Maybe non-bacterial, merantic or thrombotic. Secondary to malignancy, hypercoagulable state, or lupus. So bacteria from Jane, fever, Roth spots, Osler nodes, murmurs, Janeway lesions, anemia, nail bed hemorrhaging, and emboli. These are all terms on the test that will lead you to understanding those. Requires multiple blood cultures for diagnosis. If the culture is negative, most likely Coxiella burnetii. Bartonella, Hasek, Haemophilus, Agrobacter, Cardiobacterium, Kingella. Mitral valve is most frequently involved. Mitral valve tricuspid, right side valve, endocarditis associated with IV drug abuse. Don't try drugs. So there's a good one. Associated with also S. aureus, Pseudomonas, and Candida. Streptococcus bovis, also known as Galeotychus, is present in colon cancer. Epidermis is on prosthetic valves. Epidermitis, prosthetic valves, so plastic. You might also have rheumatic fever, consequence of pharyngeal infection with group A beta hemolytic streptococci. Late sequela include rheumatic heart disease, which affects your heart valves, your mitral, your aortic, your tricuspid. Early lesion is mitral valve regurgitation. Late lesion is mitral stenosis, hardening, narrowing. Associated with Aschoff bodies, granuloma with giant cells. There's A, looks like that, with ovoid wavy rod-like nucleus, red arrow in A. So there's your red A. Increases your anti-streptolipsin, immune-mediated type 2 hypersensitivity, not a direct effect of bacteria. Antibodies to M protein, cross-react with self-antigens. Treatment, prophylaxis, penicillin. Penicillin for rheumatic fever. Jones, major criteria, joint, migratory polyarthritis, carditis, the heart, nodules in the skin, subcutaneous, and erythema marginatum, effevents, rash with ring margin. And Sydenham chorea would also be an indication of rheumatic fever, and that should be on the test as well. And then finally, acute pericarditis, this will be the last slide. Inflammation of the pericardium, there's your red arrows. Remember, it's the surrounding of the heart. Presents with sharp pain, aggravated by inspiration, a lot of pressure. Relieved by sitting up and leaning forward. Make sure you know that. Sitting up and leaning forward. I know one of the test questions I saw gives you this description, so you would have to know that it's acute pericarditis. Often complicated by pericardial effusion. So there's your effusion between the two yellows. You get friction rub. ECG will have changes, so widespread ST segments, PR depression. Causes include idiopathic, presumed viral, confirmed infection, like Coxsackie virus B, neoplasia, autoimmune, uremia, cardiovascular, and radiation therapy. Dressler syndrome,